Dr. Christina Weng, who's the Associate Professor of Ophthalmology at the Baylor College of Medicine in Texas. And the second speaker would be Dr. Prithvi Mrityunjay, who's at the Stanford University. I would now invite Dr. Christina Weng to give her talk on subretinal gene therapy. Over to you, Christina.
Thank you so much, Dr. Raja, and thank you very much to all of you for having me. Good morning. I'm going to get things started here. Can you see my screen?
Yes, Christina.
Yeah, the screen's visible.
Perfect. Thank you so much again for the invitation. I'm going to be talking a little bit about subretinal gene therapy and sort of where we stand in 2021. It's a very exciting area. These are my disclosures, none of which are relevant to this talk. So as we all know, gene therapy is really a burgeoning space. We have come such a long way over the past 4 decades since gene therapy was first explored in the mammalian model in the late 1970s. And you can see I've clipped this from the FDA. The FDA is the regulatory agency in the United States. In January of 2020, there were 900 investigational new drug applications sitting on the desk of the FDA. That's how much interest there is in exploring gene therapy, not just in ophthalmology, but for many different types of diseases. And I bet you that number is even larger just a year later. There's many different types of gene therapy, and they really go back to what type of genetic disease you're trying to treat. So the most common type is the autosomal recessive loss of function inherited retinal diseases in ophthalmology. And we address those through gene augmentation, also known as gene replacement or gene supplementation. A great example of this is Veredogene Parvovec, which many of you have heard of. This is from Spark Therapeutics and used to treat RPE65 deficiency. The second genetic disease type is autosomal dominant gain of function inherited retinal diseases. These notoriously and historically have been more challenging to treat, but we are making progress in this area. This requires gene suppression or inactivation, which is much more challenging from a pharmaceutical and biochemical and genetic approach. But things like small interfering RNAs and antisense oligonucleotides may get us to that step. And you have also probably heard of gene editing with CRISPR-Cas9, an RNA-based type of technology that allows you to actually very specifically edit out parts of the genome. And that's being looked at for diseases like Leber's congenital amaurosis type 10 with the Editas and Allergan collaboration there. And finally, multifactorial diseases are now being treated with gene therapy, right? Things like macular degeneration, which doesn't have a single locus where a genetic mutation is found, but we can still use gene therapy by leveraging the eye as a biofactory that's able to produce its own protein substrate, such as RGX314 and ADVM022, which allows the eye to produce its own supply of anti-VEGF. And the way gene therapy works, just on a schematic and overview approach, is that you have this transgene, which carries a modified DNA sequence. And this is injected into the cell nucleus. And the way it enters into the cell is actually through a vector, which is either a viral or a non-viral vector. And then the vesicle breaks down inside of the cell, and the vector then injects that new transgene into the cell nucleus, allowing the cell to produce this new protein. And this protein can either be a native protein like RPE65, or it can be a non-native protein like anti-VEGF, as I was alluding to earlier. And we've become much more sophisticated in our designs and our delivery of gene therapy these days, such that any part of the schematic can really be tinkered with. We can adjust vectors and the capsids on the vectors. We can adjust the gene cassette itself with inverted terminal repeats and promoters. And we, of course, can really be sophisticated now in the transgene itself. There are different diseases, many different diseases in the ophthalmology space that are being looked at as targets for gene therapy. And you'll see the classic inherited retinal disease, these rare diseases that we've been looking at for quite some time now, like choroideremia, Leber congenital amaurosis, of course. But you'll also notice that this list now very excitingly includes common diseases as well, like diabetic retinopathy and macular degeneration. There are 3 routes of gene therapy administration. There's intravitreal, subretinal, and suprachoroidal. And when you look at the subretinal route, which is going to be our focus for the rest of this lecture today, there's really 2 approaches to that. You can go through a transvitreal approach, as you see in the top left, or there's this new way that can bypass the vitrectomy itself called a suprachoroidal approach to subretinal gene therapy. And that's what you see down below in those last row of pictures there. That's the orbit system, where you insert a catheter into the suprachoroidal space. And then once you get to the desired location, a small needle emerges and pierces into the subretinal space, depositing the subretinal gene therapy. There's no consensus on optimal approach, which is why all of these different delivery approaches are being studied. Now, there's a lot of subretinal gene therapy drugs. Can't cover them all in 8 minutes, of course, but I think if you were to leave my lecture knowing three, these are the three candidates to know. The first is Voretigene Parvovec. It's really not a candidate anymore because this has become the first FDA-approved and only FDA-approved gene therapy in the United States in the ophthalmic realm. This is an AAV2-based therapy for patients with biallelic RPE65 mutation, which clinically manifests as Leber congenital amaurosis type 2 or rare types of retinitis pigmentosa. There's also RGX-314 from REGENXBIO. This is an AAV8-based therapy that encodes a monoclonal antibody fragment similar to ranibizumab and is being studied for wet AMD as well as diabetic retinopathy. It's very exciting because the first of two pivotal trials called Atmosphere is already started and enrolling. And REGENXBIO is also looking at the suprachoroidal delivery route as well. And finally, GT005 from Gyroscope Therapeutics is important to know. This is an AAV2-based therapy a little bit earlier on in study, but essentially what this does is it increases complement factor I in the body, which is a natural downregulator of the alternative complement pathway. And that's a good thing. You want more complement factor I in these cases of pathologic states. This is earlier, like I said, in study. It's been looked at in a phase 1-2 focus trial that is still ongoing. But so far, there are some positive efficacy signals. So exciting to learn, as well as from the phase 2 Explore and Horizon trials, which are ongoing. So what about the setup for doing this type of surgery? Well, mostly it's just a standard vitrectomy setup, but with a couple of additional supplies, as you can see here. You'll need a 41 gauge cannula. That's the most common way of getting these gene therapies into the subretinal space. That's usually connected with some polyvinyl chloride extension tubing. And then the gene therapy, at least for Voretigene, comes in a 1 cc syringe. And then the way you inject it, you can either manually have an assistant inject it for you while you're at that, while you're at the scope in the eye, or you can even do it independently by connecting this with the VFC system and using a foot pedal to self-control and inject that gene therapy into it. So I want to show you a couple of videos now. This is first a 6-year-old boy with RPE65 deficiency I'm performing subretinal Voretigene for. So core vitrectomy, elevating the hyaloid. I like using intravitreal triamcinolone here because they're usually young. I remove the valve from the cannula to prevent kinking of the 41 gauge subretinal cannula, which is very delicate. You'll see me sort of touch down on the retina. You look for blanching, and then you start injecting the 0.3 cc's of gene therapy. And you can see that bleb raise nicely. 0.3 cc's is how much we're injecting. I like to slow the injection velocity down a little bit as we're crossing the fovea, and the entry site will generally self-seal by the end of the case. So you don't need to laser it or anything like that. And then we perform an air fluid exchange. This is another case of a slightly older patient with RPE65 deficiency. She's a 30-some-year-old patient, but I like this case because it shows a nice application of intraoperative OCT, which is a nice adjunctive tool in these cases. When you're dealing with atrophic retinas, which are common in these inherited retinal dystrophy patients, it's very easy to actually go into the sub-RPE space, which is not desirable. And so intraoperative OCT can really help you confirm that you are in the correct location. And so you'll see me again raising that bleb 0.3 Cs of the gene material and then performing an air fluid exchange. I also like to suture all my sclerotomies in these cases to prevent egress of the gene therapy product. And again, that bleb, as large as it looks, will be resorbed by the next day. And finally, in summary, subretinal gene therapy has the potential to transform the treatment of both rare and common diseases. Voretigene Parvovec is the only FDA-approved ophthalmic gene therapy currently available, but there's many promising candidates in the pipeline. There's lots of questions that remain, though, lots of learning to do because this is relatively a new area. What's the optimal delivery approach? What about these pigmentary changes that are starting to be reported in association with some subretinal gene therapy candidates? What are the consequences of constitutively active transgene end products? And what, of course, is the long-term durability? Is this really a one and done treatment? So lots to learn in the coming years. And I'm happy to take questions. Thank you again for the opportunity to be here today.
Thank you very much, Dr. Weng. I think that was really an illuminating talk, giving us a good overview of what are the types of gene therapies that are in vogue and sort of giving us an idea of what we can look at right up in the pipeline. A couple of questions that I had from my side. We saw the video where the patient was having the RPE65 defect. What happens in cases, because many of these diseases are multifactorial, or they involve multiple genes. So when you have that sort of a presentation, do we have an option for them? Because most of the therapies seem to be related to a single gene.
Yeah, it's a great question. And, the approach that I take, that phenotype is super common for a lot of different mutations. By looking at a patient like that in clinic, you don't necessarily know that they have a biallelic RPE65 deficiency. That is a requirement, obviously, if you're going to be treating them with Subretinal. And so genetic confirmation with testing is very, very critical in those cases to first identify those patients. And, it's interesting. The second question that you ask really is, what about these monogenetic approaches? And that is tricky, because if you take the most common inherited retinal disease, which is retinitis pigmentosa, there's over 100 genetic mutations that we've identified. And it would really take forever to really go through a research program for each one of those mutations. And so we're really looking beyond gene therapy as well to technologies like optogenetics, things that can bypass the specific mutation itself, but potentially still restore visual acuity or visual function to these patients.
Can I ask one question, Vivek, to Christina?
Yeah, please go on, Dr. Narayan.
Yeah, wonderful, Christina. Thanks
Thank
for
you.
the presentation. So I had a question on the pricing of Luxturna. How is it reimbursed? Are there any criteria for patients to be selected? And who can do these surgeries? Is any vitreoretinal surgeon allowed to do, or there are some centers where they have to be done?
Yeah, great questions, Dr. Raja. So Subretinal and Parvovec took an interesting approach, and I think they really set interesting precedents, being the first FDA-approved gene therapy that a lot of subsequent companies in therapeutics may follow in the future. They chose 10 centers of excellence. Baylor is one of them, which is why I'm able to give Subretinal in my practice. But there's 10 centers of excellence in the United States that where the surgeons have gone through specific training to be able to do this. And in terms of the pricing, it is very expensive. As you know, the R&D for these gene therapies is pretty immense. Each eye costs $425,000 US, which is probably the most expensive medication that we use in ophthalmology. But thankfully, they have a really good program that's set up. So first of all, the hospitals and physicians don't incur any of that cost. The cost is directly paid from the payer itself. And that's an arrangement that obviously takes a lot of groundwork before the patient is even approved. Now, in terms of approving the patient, you have to prove a biallelic RPE65 mutation through genetic testing, but you also have to, based on the retina specialist judgment, you have to be able to say that you think there are viable cells. And that's obviously a very hazy interpretation, but we do that with a combination of looking at the OCT, the overall vision, et cetera, and you try to make a judgment call. Right now, the reimbursement is not dependent in most cases based on their outcome, but that's been something that's been talked about, especially for future gene therapies. People have thought about perhaps linking the reimbursement of these very expensive medications to the patient's outcome. And, that gets tricky, obviously, for many reasons. I'll save that conversation for another day, but I hope that answers those questions.